Your patient is on the operating table, halfway through surgery, and something is wrong. The carbon dioxide on the monitor is climbing and will not come down, no matter how you ventilate. The jaw is rigid, the heart is racing, and the temperature is starting to climb, fast. This is malignant hyperthermia, a reaction to the anesthesia itself. You have minutes, and one drug that matters most. Do you know it? Here is your question. During surgery, a client develops a rapidly rising end-tidal carbon dioxide, jaw and muscle rigidity, a racing heart, and a temperature climbing toward 106. Malignant hyperthermia is suspected. Which action is the priority? A. Administer IV Dantrolene. B. Apply cooling blankets and ice packs to lower the temperature. C. Give a beta blocker for the fast heart rate. D. Increase the anesthetic depth to relax the muscles. Pause right now and commit. 3, 2, 1. The answer is A. Dantrolene. Malignant hyperthermia is a runaway release of calcium inside the muscle, and dantrolene is the only drug that shuts that release off. Everything else, the cooling, the oxygen, the electrolytes, matters, but none of it reverses the reaction. And the very first move, alongside the dantrolene, is to stop the anesthetic that triggered it. Here is why. In a person with the genetic trait, a trigger, a volatile anesthetic gas or the paralytic succinylcholine causes calcium to pour out of its stores inside the muscle cells. The muscles lock into sustained contraction. That burns fuel at a furious rate, and the body pumps out carbon dioxide and heat. You are here. The carbon dioxide soaring, the muscles rigid, the temperature climbing. If it runs, the muscle breaks down, potassium floods the blood, and the heart arrests. Here is what saves the patient. Catching it early, and the earliest sign is not the fever. Early, you see the carbon dioxide climbing on the monitor, a fast heart, and often a rigid jaw right after the paralytic. That rising carbon dioxide is the very first clue. The fever comes late, and by then the muscle is already breaking down, the potassium rising, the rhythm at risk. If you wait for the temperature to convince you, you have already lost minutes you need. So here is the order of operations. First, stop and treat. Stop the triggering agent immediately, and give dantrolene. That is the only thing that reverses it. Second, cool and ventilate. 100% oxygen. Hyperventilate, and cool actively, with ice and cold fluids. Third, fix the fallout. Treat the high potassium, the acidosis, and watch for muscle breakdown and dangerous rhythms. Here is the rule to carry out of this. In malignant hyperthermia, stop the trigger and give dantrolene immediately. The cooling and everything else come after the antidote, not instead of it. So how do you recognize it? Start with the trigger. It happens during anesthesia, from a volatile gas, or from succinylcholine. Then, the signs: a rising end-tidal carbon dioxide, the earliest clue, a rigid jaw or rigid muscles, a racing and irregular heart, and a temperature that soars, late. And a family history of trouble with anesthesia is a huge red flag, because this trait is inherited. Rising carbon dioxide with rigidity, under anesthesia, means suspect MH, and reach for the dantrolene. 2 treatments, 2 different jobs, and the order is everything. Cooling brings the temperature down, but it does nothing to the reaction that keeps generating the heat. Dantrolene works upstream. It stops the calcium release inside the muscle, which is the engine of the whole crisis. So dantrolene stops the fire, and cooling clears the smoke. If you cool without giving dantrolene, the temperature just climbs right back. Antidote first. Now 2 instincts that cost you time, because in MH, time is muscle. First, waiting for the fever. The temperature feels like the confirmation, but it is a late sign. Act on the rising carbon dioxide, not the thermometer. Second, leaving the trigger running. If the anesthetic gas is still on, or someone reaches for more succinylcholine, you are feeding the reaction. Shut every trigger off the moment you suspect it. 2. To lock in. For the sequence, stop, Dantrolene, cool, correct. S. Stop the trigger. D. Dantrolene now. C. Cool, and ventilate. And correct the potassium, the acid, and watch for muscle breakdown. And for the early tell, carbon dioxide before heat, rising carbon dioxide first, then jaw rigidity, then the racing heart, and only late, the fever. See the CO2 climb, and move. Now the wrong answers. B. Cooling blankets and ice. Cooling is part of the treatment, and you will do it. But it only fights the heat, not the cause. Without dantrolene, the hypermetabolism roars on. That is the trap. C. A beta blocker for the heart rate. It slows the pulse but does nothing to the calcium release driving everything. And D. Deepen the anesthetic to relax the muscles. That is backwards, and dangerous, because the anesthetic gas is the trigger. You stop it, you do not add more. Tie it together. Your cues. A rising end-tidal carbon dioxide. A rigid jaw and rigid muscles. A temperature climbing toward 106. And a patient under volatile anesthesia. Your action. Stop the agent and give IV dantrolene, then 100% oxygen. Active cooling and treatment of the potassium, the acidosis, and the muscle breakdown. And the outcomes you are steering toward. The muscle relaxes. The carbon dioxide and the temperature fall. The muscle breakdown caught early. And the patient survives. Now test yourself, fever and rigidity, just like MH, but this patient is not in the operating room. He is on an antipsychotic medication, and this built up over days, not minutes. Is this malignant hyperthermia? No. This is neuroleptic malignant syndrome. It looks the same, fever, rigidity, a sky-high muscle enzyme, but the trigger is a dopamine-blocking drug, not anesthesia, and it comes on over days. You stop the antipsychotic, cool and support, and dantrolene or bromocriptine can help. Same appearance, different trigger and timeline. One more, just after induction, before any fever. Your patient got succinylcholine, and now the jaw is clamped rigid, and the carbon dioxide is creeping up. No temperature yet. Wait and watch? No, treat it as MH. A rigid jaw after succinylcholine with a rising carbon dioxide is an early warning, and waiting for the temperature throws away your head start. Stop the triggers, get the dantrolene, and treat. The fever is the late sign, not the starting gun. One last look. The crisis is controlled with dantrolene, but now the urine in the catheter is tea-colored and the muscle enzyme is sky-high. Are you done? No. That dark urine is myoglobin from the muscle that broke down, and it can injure the kidneys. Push fluids and watch the urine output and the potassium. And because MH is inherited, flag the chart, tell the family, and plan trigger-free anesthesia for next time. The crisis ends, the follow-through does not. Next episode. Minutes after a dose of a new medication, your patient's throat is tightening, hives are spreading, they are wheezing, and the blood pressure is dropping. This is anaphylaxis, and there is one injection that reverses it if it goes to the right place. What is it, and where does it go? That is episode 8.